Good morning everybody. Assalamu alaikum. I am Dr. Paresh Doshi from Bombay, Jaslok Hospital, India. My previous speaker has already spoken to you about the medical treatment of Parkinson's disease, and I take the liberty of talking to you in English. I know that all of you might not be conversant in English, but I am not very proficient in Urdu, so please pardon me. I will try to explain you as simply as I can about the various surgical treatment available for treating advanced Parkinson's disease patient. Is there a hope? This is a question that patients ask me when they come and first see me. Dr. Doshi, I have got Parkinson's disease, my life is doomed, and this is where I come into the picture. This is one of the reports shows that patients of Parkinson's disease live nearly normal life. 20 years of follow-up study published as recently as 2009 has shown that more or less if the Parkinson's disease is well managed, and the important word here is well managed, patients can live a nearly normal life. In patients who cannot be treated adequately with medicine, we have many other options, and most important message that I want to give to this audience is that Parkinson's disease can be controlled. Do not expect a cure, but do expect a good control for you to live a comfortably good life. Continuous research is going on which brings in more and more hopes to the patients of Parkinson's disease, and this is in form of gene therapy or stem cell treatment. Now we need to understand what are the treatment options available to us. As I told you earlier, medical option and surgery, which can be of two forms, deep brain stimulation or lesioning. Before we go into talking about the surgical treatment of Parkinson's disease, it is very important that we understand all our signs and symptoms correctly. And this is important because many times when I receive letters or mails or description from the patient, what they feel and what they can convey to me is totally different. So I will try to illustrate various common terminology of Parkinson's disease by illustrative videos. And here this is a video of an on phase of patient with Parkinson's disease, and you can see here that his body movements are free, fluid, he is able to turn in the bed, he is able to get up comfortably, and a little bit of involuntary movement, the fidgety movement, the rolling movement of the hand that you are seeing here is called dyskinesia, and that comes with the advancement of the Parkinson's disease. The next thing is the off period treatment, off period symptoms, sorry. And here in the off period, the same gentleman is considerably disabled. You can see that how much time now he takes even to turn in the bed. It takes nearly 10 to 15 seconds for him to move on one side, same time to turn on the opposite side. Even to lift his hand is a great effort. He is very slow, his actions are limited and restricted, and he is very stiff. And this is what we term as off period. So many times when I have to inquire about the patient's condition, I ask them how many hours do you spend in on period, how many hours do you spend in off period, and they tell us exactly what they feel, and that is what the description is. Another terminology is off phase dystonia. Dystonia is a curling of toes or hand fingers, and that you can see this in this particular video, that this lady has curling of the foot toes, and that is called off phase dystonia. Usually this is a symptom associated with off periods, and it is associated with lot of excruciating pain, and this becomes an important indication for us to decide whether this patient should be offered surgical treatment. Now I will take you through various stages of Parkinson's disease when surgical treatment can be beneficial. The first stage is an early Parkinson's disease. 8 out of 10 patients of early Parkinson's disease can be very well controlled by medical treatment. However, there are 20% of the patient, or 2 out of 10 patients require some surgical intervention to control their tremors, and this is typically seen in this particular lady who has a right-sided unilateral tremor. The second phase is a phase when you see dyskinesias. When you see the dyskinesia, that is involuntary movement getting excessive, it becomes difficult for one to control the body part, and this is when you intervene again to relieve the patient of the dyskinesias. And the third step is when you see a completely disabled person, wheelchair bound like seen here, with stiffness in the hand, rigidity, difficulty to move his hand, and this is the end stage of Parkinson's disease or an advanced Parkinson's disease, and this is definitely undoubtedly the best indication or the most common indication for Parkinson's disease surgery. To talk to you in a medical terminology, who is the best surgical candidate? A patient who has been at least more than 5 years in disease duration, patient who has got on-off fluctuations, suddenly on suddenly off. Patient who expects to remain on, that is in a good movement for 3 hours, suddenly becomes off. There is a movie for which the family has decided to go today evening. At 7 o'clock we give a tablet to Abu. We know that Abu is going to get better at 6:30 if we give a tablet by 7 o'clock, but the on does not come. So, sudden on, sudden offs, unpredictable offs, these are all called motor fluctuation, and this is during this time that the patient needs an additional form of treatment, and that can be surgery. Marked dyskinesias, I already talked to you about that. Off face dystonia and pain, curling of toes, you remember earlier I showed you curling of toes, that is called off face dystonia and pain associated with that. Sometimes I have got some patients who have marked hallucinations. I had a lady who used to bang her head to the wall thinking that someone is observing her all the time, visual hallucinations, and this becomes an important indication in some patients, because in the patients suffering from severe hallucinations you cannot bring down the medicines. If you bring down the medicines, the Parkinson disease gets worse. If you keep up the medication, the hallucinations becomes unmanageable, and this is the time when an additional form of treatment like surgery helps. All the symptoms that respond to levodopa responds very well to surgery. Basically, to put it in a nutshell, if I have to give you a one statement answer as to who is the patient to be considered for surgery, when the best medical treatment does not control your symptoms adequately, that is when you should consider surgical treatment. There are some symptoms that even surgery cannot improve, and typically these are the symptoms which levodopa cannot also improve. So, symptoms like on period gait disturbances or speech disturbances during on period. In off period, if there are speech disturbances and they improve after giving levodopa, after surgery they will also improve. If the patient has got difficulty in walking in off period, but in on period he walks normally, that will also improve. However, if the patient symptoms does not improve even after levodopa, those symptoms will not improve after surgery. This is a report from New England Journal of Medicine published in as early as in 2006, wherein they analyzed 156 patients below 75 years of age, and they found that the Parkinson disease surgical treatment in the form of deep brain stimulation is a much better option than pure medical treatment. Now we come to talk about surgery and actually how we would do it, and I will take you through the various stages as we take the patient into the hospital, process the patient, work up the patient, and then bring him up for surgery. Our surgical protocol starts with a very careful screening by a neurologist and neurosurgeon together. They both have to confirm the indication for surgery and agree towards surgical treatment for the patient. Then the patient, if has got a neuropsychiatric problem, is seen by the neuropsychiatrist, and a neuropsychological evaluation is done. A basic evaluation is in terms of mini-mental test examination. A detailed evaluation by the neuropsychologist is performed in some indicated cases. After that, we have a specialist Parkinson's disease nurse. She spends a considerable amount of time with our clinical fellow to do a lot of pre-operative workup of this patient, including their videos, UPDRS scoring, and also giving them information about what to expect out of surgery, what would happen on the day of surgery, etc., etc. Usually a case of Parkinson disease admitted for lesion surgery has to stay in the hospital for 4 days. A case admitted for deep brain stimulation has to stay for 10 days. On the day 1 and 2 we have pre-operative workup and MRI testing. On the day 2 or day 3 we have surgical intervention in terms of DBS or lesion. In case of deep brain stimulation, on day 4 we go with the implantation of the pacemaker, and from the day 5 onwards till the time of discharge the programming starts. There are 3 different targets for surgery in Parkinson disease patient. The most common is the subthalamic nucleus. The subthalamic nucleus is located, as you can see here, deep down into the brain, in the center of the brain, and it is a very small almond shaped nucleus, half the size of the thumbnail, and you have to stick your electrode or a lesioning electrode deep into that subthalamic nucleus to achieve good success. In some cases we have used globus pallidum internus as seen here as a second target, or thalamus as a third target. This is a video showing actually how the deep brain stimulations work. You can see that a pacemaker is implanted here on the chest wall in infraclavicular region. It is connected with the help of the wire behind the ear, and it is connected inside the brain to the wire, and that stimulates the electrodes. Or in case of lesion, as you can see here, there are three different types of lesion that we have made: a thalamic lesion, a subthalamotomy, and a pallidotomy. How do we do this? We have an elaborate set of surgical equipment for this, and we have made sure that we have the most latest and the most elaborate surgical armamentarium required to accomplish this surgery with good success. And you can see here this, that we have three different sets of head rings, which are generation 1, 2 and 3, including the latest generation of CRW head ring, which is very light in weight and which has a detachable mouthpiece. So, in case patient has difficulty in breathing during surgery, the anesthetist can have an access to the airway. So, that is the stereotactic frame which is being applied to the patient's head. This frame is used to locate the target within the brain with an accuracy of 1 millimeter. You can see here, then the next step is towards surgical planning, and this planning is started with the acquisition of an MRI. Here you can see two different sequences of the MRI which are used to locate the subthalamic nucleus. This is followed on the day of surgery by a stereotactic CT scan. This scan is used to identify the surgical target within the frame of stereotaxy, so that we can reach that accurately. Following this, so this is what we call anatomical localization on the basis of CT scan and MRI. However, as I say, the final proof will come from the response of the patient, and this patient has usually always been operated in awake condition. To find out the neurological response to the patient, we use a technology called microelectrode recording. It is such a precise recording tool that it can record signal from single cell, and this is done with the help of a 5 micron diameter. It is 1/20th the part of your hair, and this is that thin platinum electrode which are stuck into the cells, and you can see here that this is what we get during microelectrode recording. This is an OT setup that you see here, which shows you how the operation theater looks like during the surgery, and this is the microelectrode recording, and you can see that there is a marked difference. When we are outside the STN, there is no sound. When we are within the STN, there is sound, and when we are outside the STN, again the sound goes away. Once we have got this confirmation, we know where our target is, but we still want to confirm that this is the most efficient target in terms of response, and that is seen as seen in this video by stimulating the target and getting the control of the symptoms of the patient. And in this case, this lady has a tremor, and you will see that when we stimulate this patient, there will be complete arrest of the tremors. See, there is a complete arrest of the tremor just now when we are stimulating. So, it is very important to have an anatomical localization followed by first level of physiological localization and further confirmation that you are accurate by improvement in the symptoms. Once we have achieved that, we either make a lesion or implant electrode. In this slide, you can see 2 electrodes symmetrically implanted in this patient, and this is the way it happens. Now, we go to the actual surgery. I will show you in a 1.5 minute how we perform this surgery in the patient. This is the fixation of the patient head ring on the patient's head. You can see under local anesthesia without any trouble. After that, as I told you, we have already performed an MRI in this patient. So, we are fusing the MRI with the CT scan. This is followed by in-theater opening of the scalp flap, and a small burrow is performed, and the microelectrode recording is now started. Actually, this surgery takes 6 to 8 hours. I am trying to show this to you in a minute or so. These are multiple microelectrode recording wires gone into the brain, and we are slowly advancing at an increment of 0.1 millimeter. You can see here that the signals are very good, and here you can see that there is a lot of slowness in the movement of the patient. This is a baseline. The patient is not able to roll her hand easily, and this is what exactly is the baseline, and you will see an instantaneous improvement when we actually stimulate the target. You can see the stiffness, ratchet like action in her hand. The hand is not moving smoothly, it is like a ratchet. Now, on stimulation, you can see that the hand has become completely free, and the movements of her hand has also become easy and free. So, that is what we achieve by successful surgery, and once we have got the right target, we place the stimulating electrode with a DBS lead, as you can see here being done, to permanently stimulate that area. This is a breakup of the surgeries that we have done at Jaslok Hospital in last 12 years, and you can see that there is a large number of lesional surgeries. And why I have been putting emphasis on lesional surgeries? The advantage of lesion surgery is that it is a one-time surgery. It does not involve any hardware implantation. If performed successfully, it can give almost similar benefit to deep brain stimulation surgery, and most important, the cost of this surgery is significantly lower than an deep brain stimulation surgery. There are some other centers who perform surgeries for deep brain stimulation, but they do not perform lesion in India, and these are the centers in Kerala, Hyderabad and some in Delhi. However, none of these centers have performed a large number of patients to give them a good experience to perform this surgery in an uncomplicated manner. We will now talk on the results of the surgery. Usually there is a 40 to 50% reduction in the medication. Few patients of ours have been completely off medications also after surgery. There is a complete relief from side effects of medicines like hallucinations and dyskinesias go away. Pain is completely abolished after surgery. There is a weight gain, better sleep, patient has a good sound sleep after surgery. Depression improves in more than 80% of the patients. These are the common expected outcomes of surgery. And now I will share with you some video presentation of surgery operated patient. This is an American soldier who had come all the way from US to get operated. You can see that he is very slow in his hand movements, leg movements, and even his walking is impaired, and he is not able to walk without freezing. And the same patient now after surgery, only 4th or 5th day after surgery, you can see that he is walking naturally in the corridor, and we will just ask him to run in a few seconds and you will see him running, and he did run back to US also. This is a Georgian patient who had come to us for surgery. He is the biggest patient that I have ever operated for Parkinson disease. He weighed more than 150 kilos. It was very difficult to even settle him on the operation table, and he had been so depressed, and he had been taking at least 25 to 30 tablets per day. You can see how slow he is, how depressed his face is looking, and how much tremors he has. And this is his video immediately after surgery, and you can see that he is playing the guitar so freely and nicely without any hesitation. In fact, he talked to us and told us that he is now going to throw away all the antidepressant pills, and he is going to play guitar to his son, who is now 9 years old and who had never heard him playing guitar because since he was born he had been suffering from Parkinson's disease. These are some doctors who have been operated, and they have been, it is important that we have been able to give them back their quality of life. This is a gynecologist. You can see that he is performing a hysterectomy surgery, and on the next slide you can also see a surgeon completing an open laparotomy surgery successfully. And this is very important, because if you can restore back the dignity of patients living, money is not important, it is the dignity and the quality of life which is important, and if you can give that back to the patient, that nothing better than that. Now, as I told you, we have been able to perform lesioning with a similar level of accuracy, and this is a patient who has undergone STN lesioning. You can see his mask-like face before surgery, slowness in his movement before surgery, and on the opposite side you are seeing a freedom of his movement. You can compare these two videos when they are playing simultaneously. One side is very slow, his gait is poor, and here he is walking freely, climbing up and down the stairs. Some patients have asked me what happens to deep brain stimulation on long term. We have had a follow-up of more than 12 years, and I am happy to tell you that even my first patient who had been operated 12 years back, the first patient can today travel in a bus in a crowded city of Mumbai independently. There is a clinical deterioration, there is a progression of Parkinson's disease, but I am happy to say that the independence do continue. And here is the video of a patient who has been operated 5 years back, and you can see here that the moment we switch off the pacemaker, this pacemaker is such a thing which can be programmed from outside and we can switch on and off. So I have switched off just to demonstrate what his baseline condition is. This is actually his condition without the deep brain stimulation. We have switched it off, and you can see how slow he is. He is not able to sit up. He has been asked to cycle, he is not able to cycle. There is dystonia of his toes, and see how much time it takes to just complete one cycle of action, and when we switch it on you will see the difference immediately, instantaneously, and the improvement is like that immediately. The pacemaker is now being switched on, and you can see that there is an immediate instantaneous improvement. His hand body movements have become completely free and full, he is able to cycle, and you will see him getting up like that in a jiffy. That is the level of improvement one achieves, and he is able to walk independently, and this particular patient is even off all levodopa. We have been very particular in documenting our results, and so that we can learn from them, and this is what it shows, that we analyzed our results in 30 patients after surgery at 2 years and 4 years interval. You can see that the improvement in the motor score, that is the disability scores after surgery, has been remaining static even at the end of 4 years. Similarly, the activities of daily living score improved from 40 to 70, and they have remained static in this group of patients. And the levodopa dose, as I told you, has an average reduction of around 36% at the end of 2 years and 38% at the end of 4 years. So these results have also been published in the peer reviewed journals, as been quoted here. Complications. No surgery is without a complications. Many patients ask me, डॉक्टर साहब ऑपरेशन चंगा हो जाएगा ना, अभी कोई तकलीफ नहीं होगी ना, कोई कॉम्प्लिकेशन? I can't promise that. You can never promise a surgery without a complication. The best you can do is to make it as safe as possible for the patient, and this is done by what we call learning curve. This is the list of complications that I had in the initial first case, 50 patients. Now you can see that there were 8 complications. Out of that, when the second 50 patients were analyzed, we had only 3 complications, and this also results have been published in a peer reviewed journal called Stereotactic and Functional Neurosurgery, and you can see here that the rate of our complication has been significantly lower as compared to very large international series all around the world, including the hemorrhage complication, which has been the lowest 0.6%, which is way low below the world average of 2 to 3%. Apart from doing just routine surgeries, we have been very particular about undertaking challenging cases, and here you can see the first dual pacemaker. This is the 6th case in the world, and the first in India was done on a lady who was 74-year-old. She had a cardiac pacemaker already implanted, and we had to implant a pacemaker for her brain, and she underwent a dual pacemaker successfully. The same thing happened when we operated an 82-year-old patient. The first thing he did was to go out and buy a sari for his wife at 82 years age. He got his independence back, and that is what we were happy for. We also had the privilege of operating the lowest body weight patient. I already told you that we operated a very heavy patient, more than 150 kilos. This lady was only 35 kilos. It was very difficult to suggest a surgery to her, and she underwent a successful surgery. So was a very young patient of Parkinson disease at the age of 32. He had a Parkinson disease at the age of 18, 16 years or 14 years of disease, and we operated him successfully at the young age of 32. So we had several challenging cases that we have undertaken for treatment of this disease. Now I will spend last few minutes on talking on the stem cell, because that is one thing which every person wants to know, and he thinks that it is a magic bullet. I hope and I pray that it will turn out to be a magical bullet in the future, but unfortunately at the present time it is not. We did undertake a stem cell research project of transplanting autologous mesenchymal, this patient's own bone marrow cells, into the brain of the patient, not into the spinal cord, not intravenously, directly into the brain, and that was important. And we performed successfully 4 surgeries of this kind, and we had exceptionally good result in 2 of this patient. Other patients are being followed up, and this is the team which shows the first transplant case. This case study has been listed in the clinicaltrials.gov site, and you can refer to this site and you can see that there is hardly any study which has been performed for stem cells in the world, and probably to the best of my knowledge this was the first scientifically conducted stem cell research study for Parkinson's disease in the world. There are many clinics which offer stem cells, but I would caution you to take treatment from them, because they are not scientific, they have no authenticity, and the science does not accept them. This is the result. Initially we have got promising result, 30% improvement in the symptoms, good control of dyskinesias, and we are expecting further trials to confirm our result. It should be, my word of caution, it should be only performed in research settings and not as a therapy. This is the team, and I would like to acknowledge my group, myself, Dr. Petros Vadia, who is my neurologist, Dr. Maximiliano, who is the clinical research fellow who has been working with us for almost a year and is now going to go back to his country, Dr. Dhara, who is the neuropsychologist, and Mrs. Bharti Karkera, who is the Parkinson disease nurse specialist. I would like to close my presentation with this remark from a person called Irving Cooper, one of the most eminent neurosurgeons of his time from United States. He has said, 25 years ago, I agonized over the question of which risk is greater, the disease or the operation. The anxiety of the decision and the tension of action is still reborn over and over again. He was worried the decision of doing it, accepting the disease or the risk of getting it better. And he felt that after few surgeries he will be able to answer that, and he said till now, till the date he wrote this book, he has not found an answer. And this was no less a surgeon. He had the courage to perform 5,000 thalamotomies on the patients of movement disorder. So even if the 5,000 surgeries, surgeon still feels uncertain or shaky, it is important because that is the quality that is required in the surgeon, not to be overconfident, but to think every case as a new case and a challenge for himself. Then only he can perform the cases successfully. And the last slide is by my friend and my dear colleague who initiated his journey from Pakistan almost 7 years back, when this center was not known for anything but deep brain stimulation, and this is his message to you from him.
साइड एरिया में मेरा कास्टिंग का काम है, इलेक्ट्रॉनिक फर्नेस लगी हुई है। मुझे पार्किंसन था और बहुत लोगों से पूछा मैंने, तो फिर किसी ने बताया जसलोक हॉस्पिटल बम्बई, डॉक्टर परेश जोशी का। तो वहाँ मैं सन 2004 में आया, वहाँ आके उनसे इलाज कराया मैंने, ऑपरेशन किया उन्होंने, और अल्हम्दुलिल्लाह मैं आज भी फॉन्ड्री में होता हूँ और काम करता हूँ। और यहाँ पे अब आया हूँ तो ये मैंने चेक कराया तो ये सही है इंशाल्लाह ताला, और बहुत अच्छा चल रहा है। सबसे ज़्यादा इज्जत होती है मेरी यहाँ पर, बम्बई आता हूँ तो बस।
With that note from our friendly Pakistani patient, I would like to thank you all for a patient hearing. I once again apologize for not being able to personally remain present and share this joy of presentation with you, but I'm sure you will excuse me for the same. Thank you very much.